up and coming in the discussion and the research, and how it might have a role in movement disorders. Okay. Now I want to go forward. All right, so technical difficulties.
I used my down arrow. I don't know if that'll work.
Yeah, I have it set up, unfortunately. Okay. All right, so I have 3 points I want to go over. It's going to be fascial anatomy and physiology, the importance of the ability, why fascia needs to move. And then the third one's going to be introduce you to a certain method. So I have 3 objectives. I want you to describe the importance of the structural orientation and the angle of the fascial layers. That's sort of important. Be able to explain the importance of the ability for it to glide. And then the last one you'd complete with your assignment, which we'll talk about later. So, my why. Why is this word important for me, the fascia system? Well, it was introduced to me in 2005 during an Ola Grimsby Institute. A brave therapist got up in front of a whole bunch of manutherapists, and her name is Lori McLaughlin, and introduced this topic of fascia. Why is that really important? Well, this was sort of an area of who's who in orthopedic manuotherapy. We had 3 major institutions here: the Ola Grimsby Institute, which has always had soft tissue involved, but not necessarily looking at fascia; the North American Institute of Manuotherapy, which really hadn't done anything in that realm with soft tissue; and then the IPA group with Vicky and Greg Johnson, who weren't really looking at that fascia at the time. And of course, how was this received? It was not received well at all. But since then, NIAMP has gotten into dry needling, and the Johnsons have gotten into a lot of fascia work. So just, 10 years later. So the word started the journey, the concept for me for fascia, for always to identify and test things. And it seemed interesting because none of these people were interested in it. So it started off for me with dry needling and looking at dry needling and going through that training and why certain groups do it certain ways. And then it got into a little bit of, well, maybe let's look at the fascia system a little bit more into that training. Now, it's of interest, Gray Cook would be looking at, we need to do dry needling to reset muscle tone, this concept of tension, right, and stiffness, before you can actually get anywhere with your exercises. And through this sort of exploration of this journey, maybe it's not so much the intervention that we should be thinking about. Maybe it, like dry needling, cupping, instrument-assisted, etc., but maybe it's the location we do it at that has more value. So along comes research that always tends to break down your paradigms. And here's one that I thought was really interesting. It had to do with TBI and stroke patients. And they were looking at this idea of muscle stiffness versus spasticity, or this concept of tone coming back again. And what they were saying, and that the physicians had seen, was that there seemed to be neural and cortical mechanisms that seem to cause spasticity, but not all of those have signs of hyperexcitability. So there might be some peripheral or non-neural mechanisms thought to cause muscle stiffness. And through this theory or construct, maybe it's the hyaluron that builds up, becomes like glue at these certain points, and it doesn't allow the fascia to move. That results in the perception of stiffness. And so what the study did is they injected certain hyaluron into certain I'll term access points throughout this myokinetic chain. And they did it at 4 points in time, and it didn't matter the acuity. And it was either brain injury from a TBI or stroke. And at each phase in the time, they showed that the passive range of motion basically improves highly significant. So if you think of a chronic stroke, you think there's no way active passive limited in the same direction is going to change that quickly and maintain it. So this breaks into some other ideas of maybe for utilization for this population, but it sort of broke down that general manuotherapy construct of active and passive limited in the same direction. The only way you can do that is really hold static load. So there's a lot of research here. This is a very busy slide, and all the citations go to support this. And the whole point of me having this is to show you that this is research. You're going to have anatomical dissection, anatomy supporting some of the constructs I'm going to go through. You're going to have histology looking at this. It's going to look at the role in proprioception and this gliding, and gliding specifically at the deep fascia. That's what we're going to focus on today. So a lot of these constructs I'll come back are some of the key points, but we're looking at how the anatomy sets up the neurophysiology, and the gliding is key to that outcome. And so let's look at fascia, and you'll see it all over the body. And can you assess this, right? How do you even assess this and make it relevant clinically? Anatomy has taught us to look at origin and insertion, and it's nice and clean and pretty, but in reality, it's not that way, right? It's not how it is when you look fresh and bald cadavers. And fascia, when it's lined up, you can see that there's a superficial part of the fascia up here that has a certain orientation to it. And you'll see down here that the deep fascia has a certain orientation to it. And all of that means it has a different role. So this superficial part would be more in compressional forces, and down here would be more in tensional or translational forces. And if we look at the anatomy, we can just see on the left-hand side the superficial, the deep fascia surrounding, and then removing the deep fascia in the epimysium, which would be right here. And that's this gliding and sliding we're sort of going to talk about. And through these anatomical dissections, they've shown that it's just not the pure origin insertion. The muscle fibers originate and insert in a more expansive manner, and it sort of create this system of what they'll term myofascial expansions or kinetic chains, both anterior and posterior, agonist and antagonist, and in synergistic form. So this is supported through the anatomy, and of course from anatomy dissections, and the force transmission can actually be utilized for fascia to transmit the load. The other construct for this particular method that we're going through is the use of hyaluron, which of course is in the extracellular matrix and the glycosaminoglycan glycan, but we're looking at the hyaluron specifically in the deep fascia, and when it aggregates or has an increase in viscosity, it creates a limitation in motion and mobility that can have an impact, and that's what I want to focus on. So how can this even be influence our motor patterns and movement? Well, from some of that research in dissection anatomy, they're identifying that they think there's a high proprioceptive role for the deep fascia. It seems to be laid down in different layers, around 78 degrees in general throughout different areas of the body. It always has that same angulation. The orientation of these fibers, as you can see, on layer on top of layer here, and how it can move. And this gets to Donatelli's old paper on the paper and the cross string and the mobility aspect of it. But it creates tension in certain spatial planes, which gives the brain direction for purposeful movement, and it basically allows the right movement contracting at the right time for purposeful function. And then it gets into Richard Jackson's concept, because we've mainly been focusing on muscles. Muscles are activated by proprioceptors, and proprioception is turned on by movement. And so maybe it's the movement being picked up in this fascial layers that are probably more important than what we've looked at historically. Why is it important at these deep fascial layers? Because if it's not sliding or gliding, in the article that you guys read, it will term it as a densification. If it's not moving, it's going to affect how the proprioceptors are picking up. It's going to affect the muscle spindle and the mechanoreceptors, giving that feedback. And basically, your fascia system is constantly listening, right? Your nervous system is constantly listening to what the fascia has to give it for its input for movement outcome. As we all know, movement occurs in patterns. It's not isolatory. And so if we have a lack in motion here, it's going to affect the gliding component. It's going to affect the spatial interpretation that the brain receives, and we're focusing down on the deep fascia here now. And then the central nervous system has these preset motor programs that we've been looking at, right, in our motor control. And so if these input is off, it's not going to be interpreting it accurately, and it's going to create compensations. In another article I'll send you guys, it terms it more of a somatic equilibrium point, but it's really these anatomical locations that are the centers of coordination, which happen to be motor points and muscle bellies, or the centers of fusion, which happen to be more retinacular tissue. But the key point is the gliding and the sliding and its ability to pick up movement and the brain to interpret that. So what happens when fascia stops sliding? I just want to show you this really quick. We're going to be looking right here. This is the deep fascia. So we have the muscle and the deep fascia. And we want to look at what normal glide and slide would be like. So this is a quadricep muscle. And it's looping, so you see it contracting, going back and forth. But what I want you to pay attention is right here. What do you see and notice? And be rhetorical at this point. But what you can see is that some of the muscle fibers are moving at different speeds. Some of it is moving in different directions. Either way, it needs to move. And that constant feedback system is creating the brain's interpretation of what normal movement might be. And if we look at pathological sliding, or what we term densification, you can see how this lack of mobility is either going to lead to compensations and eventually pain if this is continually what's being perceived by the brain in a certain region. And I just want to step through this because this is the important aspect of this, the glide and slide, and we'll just watch it. And I really want you to focus on the deep fascia and how it's moving. So that would be normal motion. And it's just the histology in it, right? It's innervated. And this would be altered motion and an increased viscosity, creating almost like a honeycomb glue component. So why is this information important for your clinical reasoning process? Do we have a systematic way to assess fascia that's consistent with a whole body system that's repeatable, sort of like a Maitland construct? If we do, what do we call that method? I'm going to introduce you just briefly to one, but there might be others out there. And does it work clinically? Just got back from AOP last week, and all they're saying is, show me the outcomes. Show me the outcomes, right? And that's what your assignment's going to be geared towards. So you've read the article, and a lot of these, I'm not going to go through these, but they're to help you understand to some capacity. All this says is that we break it up into body regions. It's repeatable. We can find a sequence and look at the agonists and the synergists of that motion and or the antagonists. So it links nicely to some dry needling constructs as well. And then it's multiplanar. It can happen in one plane or a combination of planes. And these points are identified by the anatomical dissections we talked about previously. This, I'm not going to go through this specifically, but you can use your active range of motion, passive, resistance. What's the stiffness of the muscle? Does it change when I do a contract, relax type of PNF component or not? And then going to those palpatory verifications in the soft tissue and see if you're finding these limitations in glide and slide. Now, the only important part about this, and which got me excited, is now I can put it to a plane. I can put a limitation to a certain movement pattern that I see dysfunction in, and if there's limitation in that glide and slide, I can then systematically treat it if it's applicable, even if you need to. The question would be, do I need to put a manual therapy input, or can I just do Sauerman? Well, that's possible. But this allows you to, and just like joint mobilization, sometimes you need to put it on there and sometimes you don't, right? But fascia it has these anatomical points, and it does seem to stop moving at specific locations, just not anywhere in the body, as the article was saying. So does specificity matter? Well, using this construct of hyaluron aggregating in certain locations, it does seem to matter. You can find it accumulating anywhere. But when it aggregates in these specific spots that have been identified through anatomical dissection, right? So there's some science behind it, that it does seem to lead in either compensations or eventually pain or dysfunction. And the take-home message here that I want to reinforce with the article's help, because there's no way you're going to get this without reading that article, is that this normalizing the mobility at some of these key points provides that optimal movement pattern of the vectors, so that it gives that sensory motor type of impact for the input coming back from the brain. And so the the fascia is connected in the antagonist, agonist, and then of course in the synergist myofascial expansion, which we talked about. It's very systematic. The Yonda told us that muscles tend to be the window to the health of the central nervous system. And that's what physical therapy is focused on for the longest time, is looking at muscles and muscle function, muscle length, etc. Instead, maybe we should be looking at how well fascia mobility, we're just poking on one aspect, maybe the fascia mobility might be a better window, and we'll see where research leads us in the future. These points are just to give you some anatomical reference for your palpatory findings. The circles would indicate that they're in a one plane, and the triangles would be indicative of a combination of two planes, or the centers of fusion. And the points are just to show you that where do you find your soft tissue limitations when you're palpating, and how do you use that? And we'll look at some of those questions. And then, of course, up here we'll look at the scapula, just looking at some different points, because they're common areas we find dysfunction. Can you put those limitations to a certain movement pattern or plane? And that's what excited me about this type of assessment. So let's look at an example. This was a quad strain, 32-year-old female coming in within 2 weeks of the quad strain. I believe it was a grade 1. So it wasn't severe. But that's her mobility. And the passive was only a few degrees more. And this is Larry, a gentleman I've done research with, but he did an assessment. He's going to treat two areas. And like any good clinician, he doesn't let you see what he's videoing, right? But he did one in what we call the genu, or the knee, and one he's going up to what we'd call the hip, the coccyx. 2 points. Same session. And my question is, when you saw that, how would you have treated? He's looking at full motion. He's not getting full motion. What he'll do is he's going to go 2 other planes that sort of work on some of the full knee flexion, the rotatory component. And he'll work at another segment in what would be considered the knee, and then another one that would be considered the talus, or obviously in the calf. And now he's getting the result he wanted. By restoring that glide and slide, the idea is the motor control component comes back. Obviously, if this was a chronic patient, the outcome is going to take longer and not be as neat to see. But it reinforces the construct. The take-home message that I want to give you guys, and start your exploration on your own, should this be of interest, is that there probably are more points that are probably more efficient to use and spend your time. And they can be mapped out, and if they're mapped out, they better be mapped out, in my opinion, through the anatomical dissection and relevance to it. And they should be consistent with functional movement, how we move. Of course, when you restore that mobility, you're likely going to restore the motor programming. So this gets back to, I need to reset it before I can go in and actually have a benefit for my motor plan. And these points, or these centers of coordination, which again are in motor points primarily, in the muscle belly, and the centers of fusion, which tend to be more around retinacula. These are the areas you want to spend your time working on or looking at in your assessment and in your treatment interventions. My suggestion, anyway. At this point, we know this much about fascia, right? You're going to see more of it coming out in the next 10 years. I think where we were at with manipulation literature 10 years ago, now that no one questions that. But I put this on your radar because I think that's what you're going to see. And my challenge to you would be, okay, don't take what I say. Go check it out. Let's have you go ahead and ask a question. Does this work clinically? Take it to an outcomes question and do a little PICO on it and do literature research, but specifically on fascial manipulation and compare it to the other outcomes. And there's plenty out there. There's low back, there's knee, there's shoulder, there's hip. You're going to find different things out there. Go compare its methods and go from there. And again, this is just one method. Choose another method if you like, but I think this is the most repeatable method. And of course, I'm going to have a little rubric there so that you know how I'd grade you on that assignment. I have some questions for you guys because I want to learn. Do you guys assess the soft tissue mobility with your patients? If you do, how do you use it? Do you choose interventions out of it? Exercises? Come on, I got to hear some feedback because I'm tired of me talking.
Yeah, so I do assess kind of the glide and slide of tissue with.
We lost you, Nick. Nick, looks like you froze up a little bit. You still there, Nick?
Yeah.
Yeah.
So I do assess tissue slide glide and kind of fascial restrictions, whether it's by my hands or something like rock pods or some cupping or whatnot, and I use that to maybe I'll use that information when I'm prescribing an exercise or.
Oh, we lost you again, Nick.
I have given more of a movement. Can you hear me?
You're cutting in and out, Nick.
All right. I would give a more of a movement approach to that activity where I'm kind of stretching out that whole fascial chain and then reassess afterwards and see if that makes a difference before I go hands-on.
Okay, good. Matt?
I assess it just like I would any other impairment. If the patient gives me signs and symptoms that would suggest that that's something worth assessing, I will assess it, and then yes, it will influence my intervention selection because I'm trying to find the primary impairment. If that leads me down that path, then yes, through palpation and through treatment of that tissue as a diagnostic intervention, if that has an effect, then that's where I'm going to focus treatment, just through accessories, as Nick mentioned. But I don't use rock pods. Maybe I should, or cupping. It's just my hands.
Have you guys noticed that there's common patterns where you tend to find restrictions or tender spots or however you want to label that? Do you notice that they seem to be in consistent regions and areas?
Go ahead, Michael.
Yes, I've previously kind of utilized the Simons and Travell trigger point document in their book and resources where they've kind of mapped out the different muscles and the predictable points within those muscles. For instance, just this evening I was focusing on the levator trap, and consistently there's a trigger point that it honestly matches up with some of the ones that you showed on the scapula, right at the insertion as well as at the twist of the levator scap. So that would be an example, and yes, I do find a predictable pattern.
And now what I would say is put that pattern to a spatial plane of movement and then see if you find something down chain on that same plane that actually, because the way we might find up there might be the holding pattern, but the problem is somewhere else. It might even be anterior based on the anatomical dissections they've identified in this the septa and the communication point. And just something to think about and explore when you start looking at that, especially when you first start picking up Travell and Simons.
Matt, you had your hand up?
I was going to say that I've been very, very slowly noticing some patterns, but I'm a little slow. Because, to be honest, I have disregarded soft tissue for a long time. It was until recently that I began to pay a lot more attention to it. Ironically, because of individuals, including Mike, but Claire Frank and other individuals who would have been the last person I would have assumed focused on soft tissue because of my own biases, discovered, hey, right, there's no one magic way. You need to find out what is the source of the symptoms, whether that be muscle, fascial restrictions, joint, what have you, but now realizing it's an important part of the puzzle. Well, the problem is the puzzle is pretty big.
Amy.
I do use many different types of soft tissue techniques. I'm also done some soft tissue instrumented techniques. But I think some of that discovery came from, again, population dancers post-surgery with scarring and the restrictions that scarring have, and those fascial adhesions that I'd seen, and had learned something from IPA course long ago, where they basically took a mini plunger, like that you use almost for your toilet, and used it with some emollient to put it on the skin to distract the skin and pull away some of those myofascial restrictions, and had amazing results just from that. I couldn't explain it at the time, but now it makes a lot more sense.
Yeah, and I would suggest, it doesn't matter where you're doing dry needling, cupping, instrument assisted, or this transdental oscillation, like we did with Syriacs and cross friction. It matters where you do it, and in the systematic way of where you're doing it within a movement pattern. I think that's the key why I like this method, and I would challenge you guys to look into some of that, because I would want to know the information we talked about, with at least just with the gliding. Does that inform your understanding of your findings, right? How might this knowledge help you then take that information you're identifying and translate it into the clinic, and how might that change your practice for the last two? And it could be the exploration of it. As I told you, this was presented in 2005 to a lot of big no people, and they do the same thing. I was trained the same way. Joint, right? This is what we focus on. What's soft tissue? We don't do that. But maybe we need to start looking at that. And if we do, we should do it in a systematic way. And it's got to be repeatable. Otherwise, it gets into who's the guru. It has to have science behind it. It's got to be systematic.
Okay, I want to be good with your guys' time. And so, Brent, I just want to ask a couple questions as we start to wrap up then. You mentioned earlier on when you were talking, and you did a fabulous job, nice job. You talked on earlier on, and you said that you went to the conference and somebody was talking about fascia, and it was kind of poo-pooed at that time, right? Why do you think there's that negative guttural reaction that most people have to doing fascia work?
I think honestly, I think it comes from who was speaking on it at the time. And so you're going to have people like John Barnes talking about it and being the major proponent back then. But John Barnes also gets into a lot of esoteric things and a lot of things that aren't standard science-based. And a lot of it didn't have any science behind it at that point. And that's, I think, one of the major reasons. Plus, they were good at what they did. They weren't that good at doing the soft tissue. And I think there was a movement back then that we're not massage therapists, we're physical therapists. So I think there's political aspects, but I think the major reason was that it didn't have the literature behind it. And the people who were proponents of it weren't your researchers.
Good. And then as we start to take a look at things like movement science and things like that, you touched on it a little bit as you're going through, but is your thought then you should look at movement science first and then fascia work, or you should do fascia before you look at movement, or what are your thoughts with that?
No hard standard. It's going to be dependent on what is appropriate for the patient. What I would say is that if you find restrictions in the fascia and they're consistent to your assessment, restore them, because you got to have the reset before you can actually have the benefit or the input that wouldn't relate into a compensation. Now, if you look at Shirley, she might have a different reason. She might say, well, if I do it long enough, I'm going to create the glide and slide, but it's going to take me 6 to 8 weeks. Whereas you talk to someone else, it's like, I want to stick a needle in that, or I want to do soft tissue on that. I'm going to restore it quicker, and then I'm going to retrain the motion. So the example I showed, if you just gave her exercises, she's not going to restore that on her own. Restore the glide, allow the motion and the brain to perceive that, and then you can have a better outcome with your exercise or movement control. So I wouldn't say it has to be hard and fast, only if it's there.
Okay. And then last question, where do you think literature needs to go with your topic?
I think the literature needs to go in stronger randomized controlled trials for outcome-based intervention. It's got the research behind it now. Many people are looking at, they've shown the anatomy and how it varies. They've shown that it has the histological components to it. It's innervated and all these things supporting it. Now you need to look at the system and compare that and see how the outcomes are. And once you show outcomes, then practicing clinicians will be more interested in learning it. And again, I'm not saying you have to learn this method. I'm saying that from this research, it seems that these areas have more value to put input in and spend time on than just doing it anywhere. So I teach for Graston, and I've had ASTEM courses. They'll teach you to just scan and find an area, but you're not guaranteed to get an outcome or as good an outcome if you're just hunting for something without putting it together systematically.
That's great. And then Jackie was just saying it'd be nice to see it in other populations too. People who have tone and spasticity. I'm sure if you take a look at people with PEDS and things like that, it'd be interesting as well.
Well, and I think that article I showed, I think that might be your window of opportunity to make changes in those folks by restoring that, and then it allows all the stuff we're learning in our motor control course to have a better impact on outcome. That might be your window to get in there and make changes even with those folks that are super chronic, because it changed the passive motion, which I wouldn't expect.
Yeah. So, Nick, Brent, way to start us off. Thumbs up for everyone, right? Nice job. Who's up next time? Matt's up, and who else? Let me see. Scroll down.
I think Mike.
And Michael's up next time. Great. Well, you have some work to do to follow